Hello. On behalf of CME Outfitters, I'd like to welcome you to today's educational activity titled Reimagining Management of Generalized Myasthenia Gravis, a focus on FcRn antagonists. Today's program is supported by an independent educational grant from argenx US Incorporated. This activity may include discussions of products or devices that are not currently labeled for use by the FDA. All conflicts of interest have been mitigated. I'm Kristen Edmondson. I'm the Director of Neuromuscular Medicine at the Swedish Neuroscience Institute in Seattle, Washington. I'm joined today by a superb panel who I'll ask to introduce themselves, starting with Dr. Neelam Goyal.
Hello, good evening. Wonderful to be here. I'm Neelam Goyal. I'm a clinical professor of neurology and neurological sciences at Stanford University in the Division of Neuromuscular Medicine.
And I am Nicole Van Els, nurse practitioner practicing at the Department of Neurology at Michigan State University in the Department of Neuromuscular Medicine, and also assistant professor at the College of Nursing at Michigan State University.
Thanks so much for joining us today. I'm really looking forward to a robust discussion of FcRn inhibitors in myasthenia gravis. So we have several learning objectives today. The first is to evaluate the mechanism of action, the safety and efficacy of FcRn antagonists in the treatment of generalized myasthenia gravis. Second, we'll discuss how to identify patients with generalized myasthenia gravis who may be appropriate candidates for treatment with FcRn antagonists. And finally, we'll discuss developing optimized and individualized treatment plans for patients with GMG who are on FcRn antagonists. Now I'll hand things over to Neelam to talk about how FcRn antagonists work in myasthenia gravis. Thank you so much, Neelam.
Thank you. So let's start off with a question for the audience. It'll give us a better sense of how familiar you all are with FcRn antagonists. So have you used an FcRn antagonist to treat myasthenia gravis in your clinical practice? All right, so it sounds like for about 17% of you, you may be familiar but have not found the right patient. And for a vast majority, you have not seen or do not see patients with myasthenia or are not familiar with these agents. So I think for those of you and others, this will be a very informational, informative session. So what are neonatal Fc receptors and antagonists? So the neonatal Fc receptor, also referred to as FcRn, rescues IgG from cellular degradation. And these antagonists block this action and result in degradation of IgG. In generalized myasthenia gravis, this reduces the amount of circulating pathogenic antibody and thus leads to improvement in disease state. Currently, there are 3 FDA-approved medications for the treatment of GMG that are FcRn antagonists, and these include efgartigimod, rozanolixizumab, and nipocalimab, and we have a few in development, including batoclimab. Now we'll watch a brief animation about how FcRn antagonists work in myasthenia gravis.
Myasthenia gravis is a chronic, antibody-mediated autoimmune disorder characterized by fatigable weakness of skeletal muscles. It is driven by pathogenic IgG autoantibodies, which target components of the neuromuscular junction. These antibodies impair neuromuscular transmission through receptor blockade, complement activation, or receptor internalization. The persistence of these pathogenic autoantibodies is partly maintained by the neonatal Fc receptor, or FcRn, a key regulator of IgG homeostasis. FcRn binds IgG in acidified endosomes, protecting it from lysosomal degradation. It then recycles IgG to the cell surface, where it re-enters circulation. This process extends IgG half-life by approximately 21 days. In autoimmune conditions like myasthenia gravis, this recycling pathway contributes to the sustained presence of pathogenic IgG autoantibodies to amplify and perpetuate disease activity. FcRn antagonists are designed to disrupt this cycle. These agents competitively bind FcRn, preventing its interaction with IgG, accelerating IgG catabolism. This results in a rapid, dose-dependent reduction in circulating total IgG, including pathogenic autoantibodies. Importantly, FcRn antagonists do not block the binding site for albumin on FcRn, so levels of serum albumin are not impacted by FcRn antagonists. By exploiting a fundamental mechanism of IgG recycling, FcRn antagonists offer a novel, mechanism-based strategy to rapidly and selectively reduce the autoantibody burden in generalized myasthenia gravis.
All right, that was a great animation. So we'd like to just spend the next few minutes reviewing the clinical trial data from our 3 approved agents. But before we do that, let's quickly talk about some outcome measures. So first, and the one that is our primary outcome measure in our clinical trials is the MG-ADL, which stands for Myasthenia Gravis Activities of Daily Living. Now, this is a patient-reported outcome measure. We ask the patient to think about the last 7 days and ask which of these symptoms they've had. And we ask questions about 3 domains: ocular, bulbar, and limb. The maximum score is 24, and the lowest would be 0, and a decrease of 2 points is considered clinically significant. For MG-ADL and our other outcome measures, the higher the score, the more symptomatic the patient. You may have heard of the term minimal symptom expression. This implies an MG-ADL or 0 or 1, and so this is a patient with no or very little disease activity. QMG is different. This stands for Quantitative Myasthenia Gravis Score, and as the name implies, this is an objective outcome measure. So here we get the points based on what we see on exam. We test strength in 13 areas. This is primarily done in a research setting because it takes about 30 minutes to complete. Again, the higher the score, the more severe the disease. 0 is normal, and 39 is the maximum score. A change of 3 or more points is considered clinically significant. Now let's quickly review the clinical trial design and data for our 3 agents. So our first in class was efgartigimod, and this was studied in a phase 3 ADAPT trial design. This allowed patients that had myasthenia gravis with generalized disease that were both antibody positive or negative that had at least an MG-ADL score of 5 or greater. Upon entry, patients were randomized to either 4 weekly infusions of efgartigimod or placebo and followed by a 4-week off period. The primary endpoint was the percentage of responders after this first treatment cycle that were AChR antibody positive. And a responder was a patient that had a 2-point or greater decline in their MG-ADL for at least 4 consecutive weeks. The study went on for 26 weeks, and after that first cycle, patients were allowed another cycle if they had worsening of disease with their MG-ADL up to 2 points within their entry MG-ADL. And then they went into an open label extension. So here we see the results of the AChR antibody positive patients after the first cycle. And you can see the results of the patients in orange are those that were on efgartigimod. And you can see after treatment, both their MG-ADL and QMG declined, which means that their symptoms got better and then slowly worsened again to baseline after the treatment was withdrawn. Next, we move on to rozanolixizumab, which was studied in the phase 3 myCarenG trial. This was different in that seronegative patients were not included, and they had an MG-ADL and a QMG criteria for entry. Patients were randomized to placebo and 2 different doses of rozanolixizumab, had weekly treatment for 6 weeks, and then had an observation period, followed by open label extension. The primary endpoint of this study was a change in MG-ADL score from baseline to day 43. So here we have the results of MG-ADL and QMG. In the maroon and the red, you can see the results for the low and the high dose of rozanolixizumab. And similarly to efgartigimod, you see that after treatment was started, both outcome measures were reduced, meaning the patients got better, and then they returned to baseline when the treatment was stopped. And lastly, nipocalimab was studied in the phase 3 Vivacity MG3 trial. Here, patients were randomized 1-to-1 to placebo or nipocalimab, which was given in a loading dose followed by a maintenance dose every 2 weeks. This trial design is different in that patients were given continuous treatment. The primary endpoint was mean change in MG-ADL total score from baseline, average at weeks 22, 23, and 24. And here again, we see the results of the MG-ADL and QMG with the results for nipocalimab in green. And you can see after enrolling in the study, both MG-ADL and QMG had a decline, and this was maintained throughout the study. Regarding side effects, all three agents are pretty well tolerated, and we see common side effects between all three. Most commonly, we see side effects including headache and mild infections like URI and UTIs. We can also see unique side effects like diarrhea, pyrexia, and peripheral edema in some of the agents. Now that we know a little about the FcRn antagonist for GMG, I'm going to hand things over to my colleague Nicole Vanellis, who will talk about when these agents are appropriate for our patients.
Hey, thank you, Dr. Goyle. So first I want to start with a patient case. So Amber is a 39-year-old woman who's been living with AChR-positive generalized myasthenia gravis for 2 years and is seeing you for a regularly scheduled visit. Amber is currently receiving IVIG 2 grams per kilogram every 3 weeks and mycophenolate mofetil 500 milligrams twice a day. She previously received prednisone but discontinued due to intolerance. While she has seen symptom improvement with IVIG, she suffers frequent migraines and meningeal symptoms. Her MG-ADL score is 9. Amber would like to discuss potentially changing her medication due to her continued symptoms, which are negatively impacting her quality of life. So given this information, what would you recommend for Amber? All right, so it looks like here, based on the question, it looks like the large percentage you would discontinue IVIG and initiate an FcRn antagonist. 12% of you would discontinue IVIG and initiate rituximab, and a small percent would either increase the mycophenolate or continue current treatment and reevaluate in 6 months. So here's a review of conventional therapies for generalized myasthenia gravis. There are both oral and intravenous options available. And while the onset of action is relatively quick with the use of IVIG, Plex, and rituximab, the oral alternatives may take several weeks to months to achieve maximum efficacy. None of these agents have been FDA approved for the treatment of GMG. There are also additional health risks associated with using these agents, including those related to immune suppression and apheresis. This slide shows a recommended sequence of treatment posted from Belgium. There's currently no single guideline for treatment, and we know that nonsteroidal immune suppressant therapy is not ideal due to the prolonged onset of action and maximum efficacy. This is an example of what may become a burdensome treatment course for the patient, including co-management with corticosteroids. While this graph has a lot of information regarding the prevalence and mortality of MG over time, what I want to focus on is noticing the development of more effective therapies beginning around the mid-1950s. There's been improvement of the lifespan of patients with MG as we have improved access to therapy. However, there are still about 10 to 15% of patients who are treatment refractory. Half of these patients are dissatisfied with their disease control on conventional therapy and feel that their symptom suppression is insufficient. Here we have the MG-ADL and QMG scores while on conventional therapies. On the left is the MG-ADL, and on the right is your QMG scores. On average, on the left for the MG-ADL score, it was just over 7. And remember, as Dr. Goyle was explaining, minimum symptom expression is considered to be a score of 2 or less when we reviewed the data from the ADAPT trial. The QMG score averages nearly 29 points. Based on the screening tool, a score greater than 16 indicates severe disease. So as you can see, there's really no meaningful improvement in MG symptoms using conventional therapy. So this slide just shows that based on patient surveys, there is dissatisfaction of efficacy. There is the administration, time of onset, and side effects of conventional therapy based on patients' surveys. So this slide leads us to the advantages of FcRn antagonists. Compared to conventional therapy, FcRn antagonists have a quick onset of action with maximum effectiveness in 4 to 5 weeks compared to several months, have more tolerable side effects. Treatment leads to improved quality of life scores. There are customizable choices, and there is convenience of administration. There are some disadvantages to consider before prescribing. Some of these include the cost, having to trial conventional therapy, and implications of social determinants of health, including employment and insurance implications. For instance, many patients are unemployed and underinsured or uninsured due to the debilitating effects of poorly controlled MG symptoms. There are some considerations prior to prescribing FcRn antagonists. First is the patient selection. Efgartigimod is only approved for patients who are AChR antibody positive. Rozanolixizumab and nipocalimab are only approved for patients who are either AChR or MuSK antibody positive. Nipocalimab is also approved for use in adolescents aged 12 to 17. Depending on the FcRn antagonist, there are variable administration routes depending on the agent. For instance, some have continuous dosing, some have cyclic dosing schedules, some are administered IV only, sub-Q, or newly approved for the prefilled syringe. Most are required to be administered by a healthcare professional. IgG levels should be monitored regularly to assess risk for infection, and immunization with live or live attenuated vaccines is not recommended. All FcRn antagonists have phase 3 data showing efficacy. However, there are no head-to-head comparisons. Each clinical trial had different trial designs and different definitions of treatment response. However, each trial did show efficacy. It will be up to you as the prescriber and your patient's individual needs to determine the best FcRn antagonist. Other considerations include how long one agent should be tried before changing to another. Would it be worth trying a different approved administration route within the same class? And this is just a visual to remember that the patient is at the center of care, and coordination is imperative. So let's look again about how we would recommend a treatment change for Amber. And the majority would discontinue IVIG and initiate an FcRn antagonist.
Thank you so much, both Kathleen and Neelam, for reviewing that information. We're going to shift into a faculty discussion at this point, but before we do that, I want to pose a couple of questions that have been queried by our audience. So the first question is, can FcRn antagonists be combined with complement inhibitors? Neelam, would you be willing to field that question?
Yeah, of course. I think that's a really good question. From a mechanism of action, an FcRn inhibitor and a complement inhibitor are doing two very different things. One of the biggest issues is going to be, of course, costs, because these are both biological therapies and are both very expensive. The other is that the majority of our complement inhibitors are monoclonal antibodies. So the FcRn antagonists, as well as medications like IVIG and plasma exchange, are going to reduce their levels. We do have one complement inhibitor, zilucoplan, which is a small peptide that's given daily sub-Q. Because it's a small peptide, you can co-dose it with an FcRn. So again, for a very refractory patients, you could consider co-dosing, but due to some of the limitations, this would really be in a very small percentage of our patients.
Great. Thank you so much, Dr. Goyle. There are one or two other questions that I'd actually like to start our discussion, and I think we'll probably answer some of these questions over the course of the faculty discussion. So I'd actually first like to start by posing a question to both of our fantastic panelists, whether an FcRn antagonist would be right for this patient, in your opinion. Is this a patient who we've been looking at that you would consider putting on an FcRn antagonist? And are some of the other treatment options suggested also plausible? And I guess I'd like to start with Kathleen and see what your thoughts are.
Yes, thank you, Dr. Edmondson. So yes, I think this patient would be a candidate for an FcRn antagonist. She is still quite symptomatic with her generalized myasthenia gravis, and it's something that it is FDA approved for her to begin an FcRn inhibitor, given her antibody positive status. I think what I like to encourage patients is the difference between the complement inhibitors and the FcRns, where the monitoring is less. Sometimes the ease of administration can be a deciding factor, especially if we use an example of the efgartigimod with the prefilled syringe. This is something after healthcare professional oversight, the patient can self-administer every week.
Great. Thank you so much. And Dr. Goyle, I'm curious your thoughts as well.
Yeah, so I think there are many aspects about this patient that makes her a great candidate for FcRn. She is AChR antibody positive. She has generalized disease, and although we don't have her MG-ADL, it sounds like, or maybe we did, I missed it. It sounds like it's above 5. So at least she meets the clinical trial criteria. The main thing is that the IVIG doesn't seem to be working. Steroids haven't worked in the past, and thinking about her young age and all the side effects, it's probably not likely to work again. So we're looking for a therapy that's going to work quickly, and FcRn would be a great choice. I think my answer to the question that was posed before would be probably a combination of some of those things. Mycophenolate, we have to be a little bit careful in women of childbearing age, but considering, if she doesn't want to have any more children or you've had that discussion, I would increase that dose to more therapeutic, which I consider to be about 2 to 3 grams a day, in addition to adding the FcRn antagonist. And really, the way I like to explain it is kind of upstream versus downstream. With the mycophenolate, we are going to reduce the production of these pathogenic antibodies, and with the FcRn antagonist, we can quickly remove those that are causing her symptoms and get her symptom-free.
Thank you so much for that. And that actually segs really nicely into the next discussion topic I was hoping to address, which is how do you know when to move from conventional therapy like prednisone or Cellcept to some of these new advanced biologics like FcRn inhibitors? And either Dr. Van Els or Dr. Goyle, I'm eager to hear your thoughts on sort of what triggers you might use to consider switching over from a conventional therapy to a more targeted therapy.
So when I consider switching therapy, I take the patient number one into consideration, and I take a look at that MG-ADL score. So when I see patients, I have them complete an MG-ADL for me on each visit, and I can take a look at those trends and see if they are starting to trend up. Even just a 2-point change in that MG-ADL score, either 2-point higher or 2-point lower, is significant. This could be a patient that has gone from eating normally to now having to alter their diet because their oral muscles and swallowing muscles are weak. So I take a look at that. And then I also take a look at how they've been tolerating the medication, the conventional medication they are on so far. Take a look at their age and consider if this is an elderly woman or a woman over the age of 65. I don't want to continue corticosteroids any longer than I have to. If I have a type 2 diabetic, who has comorbid type 2 diabetes with the generalized MG. I certainly need to be looking after that as well. So there are lots, it can be very, very patient specific, but the main thing I'm looking at is that MG ADL score. And if I'm watching it creep up and I see my patients roughly every 3 to 6 months, depending on how stable they are, that is an indication of needing a change.
Great. Thank you so much, Dr. Van Els. Dr. Goyle, any additions to that in terms of when you consider moving from conventional therapy to the newer biologics?
Yeah, so I agree with my colleague. Really, I think we can take a step back, and the question can be, when do you want to change a therapy for your patient? What are the signs that the medications aren't working? And really, it's what was mentioned. It's that the symptom burden is increasing, and I would add the toxicity symptom is burden is increasing. So a patient may have an MG-ADL of 0 on high-dose steroids, but have tons of side effects that are impacting their day-to-day life. And so it's really thinking about meeting the treatment goals for the both for the patient and for yourself, and then realizing when a change is necessary. The benefit of about our biologics is that they do work very quickly, and some of our conventional therapies, especially the non-steroidals, can take almost a year to work. So also thinking about when do I expect this medication to work can also help you decide which tool you want to go for in your toolkit.
Great. Thank you so much. And as sort of an add-on question to this that's been posed by an audience member, is how long do you try steroids before switching to an FcRn antagonist?
The good thing about steroids is that they work very well and they actually work pretty quickly. So we say that steroids typically work in about 2 to 4 weeks. So I would say if you have a patient on a good dose, and I would say that that's probably anything above 20 milligrams, 20 to 40, let's say, and you see them back a month later and they've really had no benefit, then I would quickly move on to the next agent or be adding things. If, let's say, they come back and they are doing well, but then they have a lot of side effects, so you start to taper and they quickly have a reemergence of symptoms, then I'll be going for another medication. So when starting patients on steroids, and especially high dose, and that I would say anything above 20 milligrams, I would monitor patients very closely. There are many patients that do quite well on conventional therapy with steroids and are non-steroidals, but they require close monitoring to make sure that you're not missing remaining symptoms and the need to advance therapy.
Thank you so much. Sort of to something that you had said about, trying steroids and then potentially quickly switching to a newer biologic. Is there a role for FcRn antagonists in earlier lines of therapy? Are there instances that you, Dr. Goyle, or you, Dr. Van Els, would consider using FcRn inhibitors early before you've tried other more traditional agents in myasthenia gravis?
The data does support that if you do have a positive antibody, the data supports the use of an FcRn antagonist. And I think that helps protect the patient from unwanted side effects, putting these patients at risk for different cancers using the nonsteroidal immunosuppressant therapy, putting them at risk for osteoporosis, diabetes, peptic ulcers, and things like that. So I think there is a place for that. And I think the data supports that this is definitely an option.
Absolutely. I agree with that. And to sort of answer my own question and chime in as well, I actually don't necessarily see use of some of the traditional agents and the newer biologics as being mutually exclusive. That especially with the sort of rapid onset of action of FcRn inhibitors and some of the other targeted agents, oftentimes if a patient has really severe symptoms that aren't adequately mitigated by steroids, I'll consider using these agents early while at the same time starting a steroid-sparing oral therapy with the idea that that may enable us to come off of the novel agent further down the road, sort of to Dr. Goyle's point, where she suggested that she might actually start the FcRn inhibitor, stop IVIG, and also increase CellCept at the same time. So we can sometimes consider these a bridge therapy as well to help bring disease under control quickly in some of our more severe patients.
Yeah, and I would say some patients just don't want to be on steroids. They've been on it for something else, or they've heard about it and they're just absolutely not willing. And I think that's absolutely a situation if the disease burden is high enough where I would go for an FcRn antagonist early in the disease course.
Yeah, absolutely. Now, interesting question from our audience. Are there patients who you wouldn't consider using FcRns in? Like, are there some folks that you features you might look at in a patient and say, this is not a good candidate for FcRn inhibition?
Really, the only patient that I can think of that would not be a good candidate would be the patient who is unable to continue with the cyclic therapy. So patients who have difficulty with transportation, patients who are unable to give themselves their own injection using the pre-filled syringe. I think that would really be what would inhibit me from prescribing to a patient, would be those needs.
Thank you. Dr.
Yeah.
Guire, you anyone who you would not give FcRn to?
Yeah, I think in our community, we think about FcR antagonists like plasma exchange.
Mhm.
So if a patient was admitted for crisis and had plasma exchange and didn't respond, that might be a patient where I may pause and say, will FcRn inhibitor work or not? But to be honest, I don't recall that situation. And I think mostly it becomes an insurance issue. Do they have antibody positive disease? And then, just as some patients can feel strongly about not wanting to be on steroids, there's some patients that feel strongly about not being on infusion therapy. And so they favor the oral medication. So, kind of bringing into that shared decision making. We did see a high incidence of headaches. So, patients that have low IgG or issues with chronic infections. Now, that may not prompt me to not start because all of the other medications will also suppress the immune system other than IVIG, but I may take the patient off quickly if infections was becoming or headaches was becoming an issue.
Thank you so much. And sort of a follow-on logistical question to that. In your practices, do you monitor IgG levels in patients who are on FcRn inhibitors? Dr. Guile.
I do not. So for the clinical trial, you did have to have a baseline IgG level above 6, but in the label, there's no requirement for monitoring. If I have a patient that's having infections, I may check, but to be honest, I have not checked in any of my patients.
And neither do I.
Yeah, I don't either. I think the only exception to that is if I'm using an off-label dosing schedule, which we'll talk more about after our next series of slides and in our next faculty discussion. If I'm using an off-label dosing regimen, I will sometimes check periodically to be sure that we're not getting into a dangerous range. And then one of the final questions in this segment of discussion is, we have 3 FcRn inhibitors that are approved. We have efgartigimod, which is sort of cyclic dosing with cycles of 4 weeks and has both IV and subcutaneous self-administered options. Rozanolixizumab, which is a cyclic dosing of 6 weeks on, 4 weeks off, subcutaneous, and then nipocalimab, which is IV but every 2-week continuous dosing. How do you choose which FcRn inhibitor to try? What sort of factors do you consider when you've identified, okay, this patient may benefit for an FcRn antagonist? Are there things that are driving you to choose between efgartigimod, rozanolixizumab, or nipocalimab?
I think based on the data that we have from those phase 3 trials, we do see that they are all efficacious. And I think it comes up against insurance challenges as well as patient availability, as efgartigimod has had the new indication for, or new route for a pre-filled syringe. I have had patients requesting to come out of the IV infusion center, or they don't want to do home infusions anymore, or they want to do home self-administration. So, a lot of it's kind of patient specific, but also driven by insurance coverage.
Great. Thank you. Yeah. Dr. Boyle, any other thoughts on that, choosing between the different agents that are available?
Yeah, I agree. I think, because we don't have head-to-head studies, hard to say that one is better than the other. I would say all three are a little bit different with cyclical versus continuous, which antibody positivity we can use them for, MuSK or not able to use for MuSK, pediatric population. And so I think some of those factors plus local insurance issues can really factor into which medication we go for first.
Thank you. And then just a couple of sort of quick functional questions from our audience. First is for efgartigimod once a week with 4 weeks cycles. How soon can it be repeated? Dr. Van Els, if you could field that one. How soon can you repeat a cycle of efgartigimod?
Yeah, so we repeat a cycle in 4 weeks.
Yeah. And then sort of follow on, if you'd be willing to answer, Dr. Van Els, how many cycles of efgartigimod do you consider adequate to determine if someone is a non-responder?
So I typically like to give my patients about 3 cycles to see how they've done. Anecdotally, I can speak to that. That's about the time frame where we're going to see if they've had symptom improvement or not. And I think that the data from the ADAPT trial can help support that too. We had the first cycle, and then we had, or the first ADAPT, then we had the ADAPT extension that did show, that there was some improvement doing that second cycle of it. I have them go one more cycle. What I have seen that if efgartigimod, if we've changed routes, it often takes one cycle to get them into a newer level of baseline and improvement. So that's what I've seen anecdotally.
Thank you so much. So this has been a great discussion, and I want to be cognizant of the time. So I think we'll hand things back over to Neelam to tell us a little bit about how to individualize dosing of FcRn antagonists for our patients.
Right, thank you. That was a great discussion. So we'll come back to Amber. So like many of you suggested, Amber her IVIG was stopped and she was started on an FcRn antagonist, efgartigimod, sub-Q once weekly on a schedule of 4 weeks on and 4 weeks off. She responded well to treatment and sees an improvement in symptoms within one cycle. She continues to experience benefit with each subsequent cycle of efgartigimod. While Amber's symptoms are improving during her symptom cycles, she reports an early return of symptoms, usually about a week after the beginning of each treatment cycle. So, what would you recommend for Amber? Right. So it looks like the vast majority would alter her dosing schedule to give her 4 weeks on and 3 weeks off. And our next was increase mycophenolate to 1,000 BID, and a small percentage wanted to continue and see how she did in the next few months. All right, so we've alluded to the differences between the FcRn antagonists, but let's review them now. So all 3 agents do differ a bit on how we can deliver them, how long the infusions take, the dosing and the schedule, and this can all be part of your decision making of when to use what agent. So efgartigimod is available in an IV formulation, which is weight-based, infused over an hour, and given 4 weeks on and 4 weeks off. It is also available in a subcutaneous formulation with a fixed dose, and most recently, pre-filled syringes were also available. So these pre-filled syringes can actually be self-administered by the patient, whereas the sub-Q requires a healthcare professional for administration. The administration is very quick, within less than 1 minute, and it's also given 4 weeks on and 4 weeks off. Rozanolixizumab is given subcutaneous and it requires a specialized pump, requires healthcare professional for administration. It's given in 3 doses based on the patient's weight. The dosing is over 15 minutes and it's given over 6 weeks, 6 weekly dosing, followed by 4 weeks off. And nipocalimab, which is the newest FcRn approved just a few months ago, this is intravenous. This is given in a loading dose of 30 milligrams per kilogram, followed by continuous dosing every 2 weeks of the maintenance dose, which is 15 milligrams per kilogram, given over 30 minutes. Now, these very unique aspects of these different agents allow us to individualize dosing for FcRn antagonists. For those agents that are given in a cyclic dosing form, this offers an option for personalization. So during treatment breaks between cycles, when the patient is not on the medication like Amber, some patients experience an early return of symptoms. So cycles can be shortened or lengthened to address continued symptoms or emergent adverse events. So, for example, if a patient doesn't have symptoms in cyclical dosing by the time they're ready for their next cycle, you could consider lengthening the time between the cycles. Efgartigimod, as we had discussed before, after the first 8 weeks of the first cycle in the 26-week ADAPT trial, the next cycle of efgartigimod was based on patient response, so how they were doing. Efgartigimod was also studied in the ADAPT Next study, which we'll talk about in a little bit, which compared two dosing regimens of fixed cycle versus continuous dosing of efgartigimod. Rosanolixizumab, which we had discussed before, was studied in the MyCaren phase 3 study, where there were 6 weekly infusions followed by an observation period. This had a placebo arm. After this, the patients could enroll into 2 open label arms. The MG007 allowed for patients to be in the low dose or the high dose and get next cycle based on how their symptoms were doing. And 004 studied rosanolixizumab in a fixed continuous dosing cycle. And so here we have the results of the ADAPT Next study. So in the ADAPT Next study, after patients were enrolled, all of them received 4 weekly cycles of efgartigimod, and then they were randomized to either get 4 weeks on or 4 weeks off, or get an infusion every 2 weeks. And you can see the results on the right, and these are the MG-ADLs, and you can see that the MG-ADL was quite similar between the two groups. And so there was no statistical significance in the MG-ADL between these two groups. Also, the adverse events were similar if you gave it every other week or in a continuous format, with most common side effects being headache and mild infection. Here are the results of MG007. So just to remind ourselves, this was the open label extension where patients were on low dose or high dose rosanolixizumab, but the next cycle was based on how they were doing in terms of their symptoms. So to orient you to the graph, on the x-axis, we have the time interval between their next cycle, and on the y-axis, we have percentage of patients. And the different color bar represent the time between their first and second cycle, third, fourth, and so forth. And so really the takeaways here are that the majority of patients were able to go about 4 to 8 weeks between their cycles. And the other takeaway is that you do have some patients, a small percentage, about 10% or less, that required it even earlier at less than 4 weeks. And then there were some patients, up to 22% that were able to even go longer, 12, 24, even 24 weeks, 36 weeks before they required their next dose. So really allowing for that personalization of treatment for these patients. And so now that we've reviewed this data, let's go back to that same question that we asked. So now having reviewed that data, would you do anything differently? So what would you recommend for Amber? All right, so I think we have the same number or percentage that want to go to 4 weeks on, 4 weeks off, but we have lost our folks that wanted to increase her mycophenolate and have moved a bit to switching to Rosie or continuing her current regimen and reevaluating in 3 to 6 months.
Great. Thank you so much for that additional information, Elam. It's really helpful to see that data on the sort of way each medication is dosed and where there may some be flexibility, maybe some flexibility within each of those. Before we move on to a more robust discussion of sort of personalized dosing and FcRn inhibition, I want to be sure to answer a question from earlier that was posed a little bit earlier by one of our listeners. When would you pick an FcRn inhibitor over IVIG or PLEX, particularly now in light of this information we've presented about the sort of flexibility and adjustability of the FcRn inhibitors? Dr. Goyal, would you mind fielding that one?
Sure. So plasma exchange, I think the practice can be quite variable based on where you practice. So for us at Stanford, it's quite challenging to get plasma exchange. So for me, plasma exchange is really reserved for patients that are very refractory, and I'm not able to get them under control with other agents. But I think the question regarding IVIG and FcRn inhibition is a really important one. And I would say that for a new start, so this is a patient presenting with, moderate MG, they've been on steroids and it's not working, or they don't want to be on steroids and I'm looking for a quick acting therapy, I do go for FcRn inhibition over IVIG. With IVIG, it definitely works very well, but there are issues regarding just access. A couple of years ago, we had an IVIG shortage. And so I think, and the data as well, we have robust clinical trial data that this medication works. In one case where I may go for IVIG is that we know that about 10% of our patients will present in crisis. So if they presented in crisis and in the hospital have responded very well to IVIG, I may choose to continue that versus switch them over to an FcRn inhibitor.
Great. Thank you so much, Dr. Van Els. Anything to add there?
Yeah, just couple other things to add. In terms of tolerance of PLEX and contraindications for use of IVIG, if we do have patients that have had any kind of clotting episodes, DVT, PE, patients that may have a history of heart failure, IVIG might not be the right choice for them. And then for plasma exchanges, the tolerance of it, patients are pretty wiped out. If you can liken it with dialysis, patients often feel that sort of fatigue after that.
Absolutely. Thank you both. So launching back into our discussion of sort of personalizing and individualizing FcRn inhibition, I'm wondering in your current practice, and maybe Dr. Van Els, you can field this, is there a way that you typically start FcRn inhibitors with each of these agents? Do you start with a single cycle and then see how they do? Do you plan on giving a certain number of cycles at a fixed cadence and then adjusting from there? Do you start off with something that's sort of typical for you, or do you personalize the dose or regimen from the beginning?
Yeah, thank you for that question. So I will start with kind of a standard. I will set them up for 3 cycles. But I do see them back after the first cycle to see how they've responded. To go over any headache is definitely the number one common adverse reaction to any of these agents. So I will set for at least 3 cycles, but see them back after the first. And then personalize from there, depending if they tolerated it well, they found they've had some improvement, and I can base that on that MG-ADL. I'll let them continue. And if they've remained stable, then we will continue as such. If they had complete fall off of symptoms or fall off and had a return of symptoms, I may adjust even going on that second cycle, just depending on how the patient did.
Yeah. And for those, to follow up on that with you, for those first set of cycles, whether it's, efgartigimod or rozanolixizumab, do you do those at the maximum frequency, 4 weeks on, 4 weeks off for efgartigimod, 6 weeks on, 4 weeks off for rozanolixizumab, or do you start with a different cadence?
I do start with that original cadence of those original studies, the 4 weeks on, and 4 weeks off for the efgartigimod, and then for the Rosie, the 6 weeks on and 4 weeks off, and I start there.
Okay, great. Dr. Goyal, is that your practice as well?
Yeah, I think when efgartigimod first came out, we were struggling with, do we just give them the 4 weeks and then try to see how they're doing to decide the next dose? And I think there's just a lot of practical challenges to that. So I agree with my colleague. I, give them I order it for, let's say, 6 months or whatever insurance allows and more fixed cycles, but then really communicate regularly to see if things need to be changed.
Absolutely. And then, Dr. Goyle, in your clinical practice, do you see much wearing off? Do you have issues with those sorts of like that cyclical dosing for Rosie and for efgartigimod?
Yeah, I think Amber is a great case because, it shows that she responded really well, but she did have that wearing off. And so, yes, absolutely. I would say that I have more patients that have experience wearing off than those that I was able to go longer. But having those patients where you can go longer is great because they have to have, less treatment exposure. But yeah, for those patients that are having a wearing off, trying to see if insurance can allow for earlier dosing, and then really seeing if there are other ways like their non-steroidal or optimizing their other medications to really get their general disease better so that we can have, just better treatment responses from the FcRn as well.
Thank you. And that actually leads nicely into a question posed by an audience member is, have you run into issues getting alternative dosing schedules approved by insurance?
And I have not to date.
Really?
Once they're established on therapy, I have not. And I share Dr. Goyle's practices. I've had good experience of patients having wear off symptoms and having to adjust. And so far, no problem. I'm practicing in Michigan, and so I don't know if it's a state to state type of difference, but
Great.
Yeah, I've definitely had insurance issues. I think the 4 weeks on, 4 weeks off, going to every other week, the total dose is the same. So there's been less of an issue. But I think if you try to give it earlier, both per Rosie or efgartigimod, Nepo, we're still learning because this is still new and it's continuous. So it's going to be interesting how we're going to be changing that off label. But yes, when trying to give it earlier, I have had issues with insurance.
Yeah, that's my experience as well, is that even sometimes it varies a little bit by insurance, but even sometimes switching to 2 weeks on, 2 weeks off, or every other week dosing as an alternative regimen for efgartigimod or for some other more continuous dosing regimen for rosenolixizumab, I've sometimes run into issues having it approved. AI is a great tool to write your approval letters.
And I wanted to provide some clarity on my answer. I haven't had any problems getting the dosing schedule for efgartigimod to 4 weeks on, 3 weeks off.
Okay.
That particular dosing frequency, I have not had any problems with.
Great. Thank you. As another follow-on question to that, we're sort of talking about continuous versus cyclical dosing. With nipocalimab being sort of newer and the newly available in terms of having continuous dosing, where would you see that fitting in to your current practice? Where I imagine both rosenolixizumab and efgartigimod have been on the market for a little while. We probably all have several patients on each of those. Where do you see using nipocalimab, if at all, in treating your own patients?
I could potentially see using it for those treatment refractory patients that may require treatment every 2 weeks to help control symptoms rather than the cycles.
Yeah. No, I would say that I find the cyclic dosing a little bit frustrating, and it can be very difficult for patients to get better, almost normal, and then to see reemergence of their symptoms. So I'm excited to offer these different dosing regimens that mimic more continuous dosing, either with Nepo or with our other agents, because I do think that that wearing off is very distressing to our patients.
Absolutely. Well, thank you both. I think, we are right at the end of our time here. And I just want to take a moment to thank you both for such a robust discussion. In terms of wrapping up, I'd like to review our SMART goals that we had sort of set at the beginning of the presentation. So summarizing, hopefully some of the takeaways can be that you could consider FcRn antagonists for appropriate patients with generalized myasthenia gravis who have a suboptimal response to standard therapy. understanding the importance of routinely evaluating quality of life when assessing treatment response so that you can see indicators to escalate therapy when needed, understand how to discuss treatment options and set realistic treatment goals with patients, and then also understand more about how to monitor response to FcRn antagonists and consider sort of symptom-adapted and individualized treatment dosing when appropriate. Finally, you can visit CME Outfitters, visit the Neuropsychiatric Hub for some resources for healthcare professionals and patients. Thank you so much for joining us this evening, and thank you, Dr. Goyal and Dr. Van Els, for a lively discussion and fantastic information.